of the knees that are done in the area are total knees, and 50% of the redos that I see are partial knees. A partial knee replacement is 80% of a knee replacement. So the big misnomer is that, oh, I do a partial knee, so I'm going to be back much faster. Well, it's a little faster. If the recovery from a total knee is 4 to 6 weeks, a partial knee is 3 to 4 weeks, and you have twice the revision rate. And the important thing to realize that most of the time, not just one area of the knee is involved. So frequently, either in the course of time, the rest of the knee goes bad, or for reasons which are technical, that the knee fails. So I stopped doing partial knees. I revised so many partial knees. I think it's a really bad operation. I think there are indications, but they really got to be strict, because unfortunately a lot of them fail.
Well, with regard to the hip, could you talk a little bit about all of the problems associated with the devices and the lawsuits?
Okay, that's a great question. Okay, if we go back, the question has to do with, talk about a little bit about failure of hip replacements. We're going to go back 30 years. And what's happened is, let's go back even farther. Let's go back to the 1960s. When we started doing hip replacements, people started doing hip replacement, they found out what the quote, the weak link is. Well, the first thing they found out was that they used to use cement, and that there's a stem and there's a socket. Well, first thing they found was the sockets failed. So they went from cemented sockets to press fit sockets. And by the year 1990, pretty much 95% of hips were done with press fit sockets. Well, a little bit later they found that, well, the stems with the cement failed, and by the year 2000, almost everybody was doing press fit sockets and press fit stem. Then we started finding out, well, the interface between the metal and the plastic, there was a problem. And right around this time, people started thinking, okay, we have a couple different ways of fixing it. We either can change the materials we use, or we can change how the materials are prepared. And I can get into technical stuff, but just to make it simple, there was wear between the metal and the plastic, and they came up with different ideas. Someone said, well, let's use metal on metal like a car. And the problem with them is they all failed. Metal on metal was a terrible operation. Now we use ceramic with plastic that's sterilized in inert gases, and that's the best interface between two things. The other thing is that every once in a while, a company will come up with what they think is a great idea, and the problem is not often the case. You know, just as many ideas don't work as work. So one of my professors used to say to me, don't be the first one you're blocked to use something. And I always tell people, if you go to a place like the Mayo Clinic, which is considered the #1 hospital in the United States, they will not use any components that have not been around for at least 10 years. Because by 10 years, one, they've gotten cheaper, and two, they know they're not going to fall apart. So I like to make sure something's been around for 4 or 5 years, because it's not going to be recalled, because basically there have been problems with the metal interfaces are what usually cause the problem, and they're recalled for either some type of problem with the metal. I can get into technical, but I think suffice to say that it's important as a surgeon to use something that's been around for a little while, because the interfaces between the metal and the plastic, or the metal and the metal, are what cause the problems. Is that a good enough answer for you?
Yeah.
Okay.
If the indications are for bilateral, do you do it simultaneously, or how far do you space out?
That's another great question. I do occasionally bilateral knees. The reality is that most of the time, my feeling is that when it took 6 months to recover from a knee replacement, I'd be more likely to do bilateral. But I'm getting to a point where people are going out of home in a day, and they're recovering in a week or two. So with that in mind, I tend to wait a month or two in between. Now, there are certainly patients who either for any reason are candidates for bilateral surgery or want to do it, and it has to be kind of like the same criteria we use for outpatient. You need to be healthy, you need to be active, you need to have no major medical problems, you're at low risk. Those are times I'll consider it, but I will say that my preference is usually do one at a time. I think You know, when you're dealing, if I'm dealing with someone who's 55 or 60 and has bilateral knee replacements, I'm more likely to do it. But when I'm dealing with someone in their mid-70s or older, I think that's a lot of surgery. Now, obviously, there's always exceptions to the rule, but I'm more likely most of the time to recommend doing one at a time. But everybody, that's a case-by-case basis.
Can a torn meniscus be repaired, and is an X-ray enough to diagnose